Fast and accurate 12-lead ECGs with Tim Phelan.
Oh, hi. Where am I right now? Came in as a 45-year-old male complaining of some heartburn, maybe some chest pain. Wife says he started to feel a little sicker. Anything from indigestion to infarction or a lot of things in between. But you know, this is and I'm doing it, so it's a pretty safe bet. This poor guy's going to be having an acute myocardial infarction. Why don't you come along with us and we'll show you how to do a 12-lead EKG. You ready? Let's go.
Tim Phelan is a seasoned paramedic with more than 18 years in EMS. An internationally known author and educator, he has trained more than 25,000 paramedics and nurses on diagnostic 12-lead ECGs.
Thanks for the nice intro. You know, the American Heart Association, in Chapter 9 of their new textbook, talks about the acute coronary syndromes, including myocardial infarction. And it makes some pretty bold statements. It says that emergency care providers, that's you and I, need to be familiar with the core principles of diagnosis and treatment of these acute coronary syndromes. It also says that the 12-lead ECG stands at the center of decision-making for these acute coronary syndromes. Okay.
12-lead ECG is a routine part of the assessment of a patient with possible ACS. Included with the history, symptoms, and vital signs, the 12-lead ECG is critical to the diagnosis and treatment of the cardiac patient.
Chest pain, is that right? No. Tell me again what you were doing when the pain started.
Explain the procedure and reassure the patient. Remove the clothing on the upper body. Wipe the electrode sites with a brisk dry rub. Oily, dirty, or diaphoretic skin should be quickly cleaned with an alcohol wipe.
This is all really routine, standard stuff.
Allow the skin to dry before placing the electrodes. If necessary, shave or clip hair on electrode sites.
There you go.
The ECG is best obtained with the patient resting in a supine position, lying as still as possible for the 10 to 15 seconds required for the ECG device to acquire all of the information. The patient must be relaxed, warm, and as comfortable as possible, with all limbs supported. If the patient is uncomfortable or having difficulty lying flat, place him in a low-sitting position and make a note on the ECG printout.
Well, you get the basic idea. But I would like to take a minute to go over a couple of key points. First, scene time. Studies and experience have shown that getting a 12-lead ECG does not prolong scene time, so don't be concerned about that. Second thing, getting a 12-lead really is pretty easy. Once you've done a few of these, you'll see for yourself. The truth is, the skills you've learned already are far more difficult than 12-lead acquisition. And remember, getting a 12-lead makes a difference on scene, en route, and arrival at the hospital. Of course, to be valid, it absolutely has to be done correctly. So, let's talk about ECG monitoring in general. Everyone is familiar with leads 1, 2, and 3. You learned about them in school, you've been using them for years on your job. And when you've used them, you did it for the purpose of identifying cardiac rate and rhythm. Now, each one of those leads is a view of the heart. Each one of those 3 leads has a single positive, a single negative electrode, and a ground. The actual view of the heart is seen from the positive electrode toward the negative electrode. That's why each of the complexes have a slightly different configuration. The ground electrode helps to reduce electrical interference and helps produce a clear tracing. To get a 12-lead ECG, we must isolate only the heart's electrical signal.
The human body and external environment have many sources of electrical signals. The electrocardiograph can detect and reproduce the various electrical signals of cardiac conduction. The monitoring frequency response mode provides a 0.5 to 40 Hz view of cardiac conduction, while the diagnostic frequency response mode provides a 0.05 to 150 Hz window. This broader frequency bandwidth accurately reproduces cardiac electrical data necessary for diagnostic interpretation of the status of the myocardial muscle, which may be reflected in the ST segment of the cardiac ECG complex. The ST segment is found in the lower end of this electrical frequency window. An accelerated rate of play is assumed as the eligible receiver runs a complicated pattern downfield. The two backs protect the center and a lane is opened at angle Z for the elevation of the plane.
Whoa! Time out. That's the textbook version of frequency response. Here's the real-world version. You see, the difference between 3-lead monitoring and 12-lead monitoring is not the number of wires coming out of the machine. The difference is frequency response. In monitor quality, the machine is not attempting to reproduce the full spectrum of cardiac electrical activity. Instead, it's just focusing in on the center portion, so it can see the QRS complex, so you can do rate and rhythm. In the process, it's filtering out some artifact, which makes the ECG clearer. That's terrific. But you cannot do this for ST segment analysis, because in monitor quality, you can't see the ST segment properly. That's why the 12-lead has to be done in diagnostic quality. In diagnostic quality, the machine is able to see the full spectrum of cardiac electrical activity. Not only the QRS complex, but the ST segment as well. You notice that the artifact is seen a little more clearly as well, but because we need to see the ST segment, all 12 leads must be done in diagnostic quality.
The 12 views of the heart are taken with 10 electrodes. The 4 limb lead electrodes do not require precise anatomical placement. However, it is best to avoid sites that have a lot of hair, large muscles, or bony prominences. The upper limb electrodes can be attached anywhere along the arms, from the wrist to shoulders, as long as they are off of the torso. The lower limb electrodes may be attached anywhere from the ankles to the thighs. The 4 limb electrodes provide a total of 6 leads, leads 1, 2, 3, AVR, AVL, and AVF. All limb leads provide a view on the vertical or frontal plane of the body. The 12-lead ECG adds 6 views through electrodes placed on specific points on the chest wall. These chest leads, also called precordial or V leads, provide a view on the horizontal plane of the heart.
The international standard for 12-lead placement requires that the limb leads be positioned on the limbs and not the torso. In reality, however, some emergency departments obtain the limb leads from the patient's torso. In that case, you may opt to do the same for the sake of consistency. So, while there may be some variation in limb lead placement, there can be no variation in chest lead placement. The chest lead electrodes must be obtained from their specific anatomic landmarks. Let me show you. Find the clavicle and position your finger just below it. Move your finger until it contacts the sternal border. You're in the first intercostal. Find the second, third, and fourth intercostal space. Position the electrode for V1 just to the right of the sternum in the fourth intercostal space. V2 goes in the corresponding intercostal to the left of the sternum. Skip V3 for the moment. V4 goes in the mid-clavicular line, fifth intercostal space. V3 is positioned between V2 and V4. The V5 electrode is horizontally level with V4 in the anterior axillary line. V6 also horizontally level with V4 in the mid-axillary line. Notice we did the 12-lead ECG on the scene. This was very intentional. For a variety of reasons, the ECG may change quickly, and the early tracing may provide very valuable information. Let's take a look at some tracings. The first shows gross and obvious changes. The second tracing was obtained from the same patient only a few minutes later, and the changes have all but disappeared. That's why it's important to get the first ECG with the initial set of vital signs. Get a repeat ECG every 5 to 10 minutes, or at least with each change in patient condition.